All right, here we go. So hello, everyone. As I said, welcome. This is our sixth Health Justice Now webinar, and today we'll be talking about the path to sustainable financing for community health workers. And as I mentioned a few seconds ago, my name is Natasha Kumar. I'm a policy analyst, and I will be guiding today's discussion. Next slide, please. So this is just a quick overview of what we're going to discuss today. I'll be doing a short background level set, then we'll move right into a panel discussion followed by audience Q&A. Next slide, please. So really quick, for those of you who aren't familiar, Families USA is a leading national voice for healthcare consumers, and we're dedicated to the achievement of high quality, affordable healthcare and improved health for all. We advance our mission through public policy analysis, advocacy, and collaboration with partners to promote a patient and community-centered health system. Our 4 areas of focus include healthcare value, health equity, coverage, and consumer experience. Next slide, please. And there are various ways that you can interact with us using the Zoom webinar platform. So there's a chat function, which I think many people are familiar with. There's also a raise hand function, which you can use during the Q&A portion of this webinar, and also a Q&A box. So we'll ask that if you come up with any questions as you're hearing our conversation during the presentation, please drop them in the Q&A window so that we can address them during that Q&A portion. And again, folks are introducing themselves. That's great. If you haven't already done so, feel free to put your name and your organization, your pronouns, and where you're coming to us from in the chat. Next slide, please. So I wanted to start our background conversation with sharing broadly who are community health workers. So community health workers, or CHWs, are trusted members of their communities who, because of their relationships and training, are able to effectively provide education and support to improve the health of individuals, families, and communities as a whole. So CHW is an umbrella term for a variety of roles, which can include promotores, peer educators, and many others. But regardless of their job title, CHWs have in common a community-based approach to improving the well-being of people and communities. So they can provide a wide range of services, which can include but are not limited to helping people buy health insurance, providing preventative services, helping to manage chronic disease, basic patient education, leading community health level education classes, and connecting families to social services or community services. CHWs can work in clinics, people's homes, schools, and other community settings. And the COVID-19 pandemic shone a light on CHWs and the critical role they play within communities and the mitigation of health disparities. And the federal government also recognized their unique value and issued funding for the recruitment, hiring, and training of CHWs during the pandemic. Next slide, please. So a very basic funding landscape is that currently 17 states reimburse CHWs through their Medicaid programs. So many CHWs are reimbursed using braided funds or a combination of grants and more traditional payment models. So this patchwork of funding streams are often unreliable or can be time limited or limited in scope. And so CHWs are often not included in the planning process of these grants, which can result in a lack of authenticity in these funding streams. Next slide, please. So in order to better understand kind of the barriers and successes that the community-based workforce faces, Families USA has been hosting a series of listening sessions where we invite CHWs and other key stakeholders to share their experiences with what has been working and where there are still gaps. Next slide, please. So with that, I'm going to introduce our wonderful panelists. First, we have Maria Lemus. Maria is the founding executive director of Visión y Compromiso, an organization dedicated to a healthy and dignified life for all by supporting the transformational work of promotoras, community health workers, and other grassroots community leaders in immigrant communities, low-income communities, and communities of color. So since 2000, Visión y Compromiso has provided promotores and CHWs with leadership, capacity building and advocacy through its network of promotoras and CHWs, which now represents over 5,000 promotoras and community health workers associated with clinics, hospitals, and diverse community-based organizations in rural and urban communities across California and Nevada and throughout the US, Mexico, and Guatemala. Next, we have Richard Medina. Richard is a linkage to care specialist / community health worker at the Montefiore Health System in New York. In his role, he has acted as an educator, advocate, and navigator in patient and community-facing scenarios. Richard is an expert in linkage to care, and he has presented at national conferences and developed educational materials for both patients and training physicians. Mr. Medina's passion for improving the health of others drives his work and is seen in the way he showcases empathy and compassion for his clients. Next is Mar Velez. She is a state policy senior manager at the Latino Coalition for Healthy California. In her role, Mar leads LCHC's policy agenda to address the social determinants of health, ensure healthcare access for California's Latinx and vulnerable populations, and incorporate community voice in all policy initiatives. Mar's expansive experience in advocacy, research, and local, state, and federal government provides her with the unique insight to advance equity, justice, and accountability for public good. Previously, Mar was a congressional aide to Congresswoman Barbara Lee, where she oversaw the criminal justice, Latinx, and women's rights district issues portfolio. Mar holds a dual master's degree in public health and city planning from the University of California, Berkeley. And finally, we have Shannon Lejeusky. Shannon is a Michigan native who loves spending time with her family outdoors in northern Michigan. She has spent the past 22 years serving the most vulnerable community members through outreach, education, health policy, and advocacy. Passionate about community impact, Shannon is a strong advocate in supporting the expansion of community health workers, assisting those who are experiencing homelessness, and helping to eliminate food insecurity. EDL is a consulting firm, she is the CEO at Everyday Life Consulting and founder of the Rural Community Health Worker Network. EDL is a consulting firm that focuses on building individual, organization, and community capacity to address social determinants of health through clinical community linkages and CHW sustainability. So with that, I'm really excited to jump into this discussion with our amazing panelists. There are some resources at the end of this presentation, which will be uploaded to our website at the end of this session. So you can look out for that. But now let's go ahead and jump in, and let me bring all of our speakers on board. Okay, looks like everyone is here. Perfect. All right, welcome. Let me just pull up our questions really quick. So I thought we could open up the session with a quick kind of round robin question to provide a little framing for our conversation. So if we can, let's go around this panel and share what sustainable financing of the community health workforce looks like or means to you in a couple of sentences. And I'll start with Maria.
Thank you, Natasha, and thank you so much for inviting us to be part of this important discussion. For me, sustainable financing means the ability for community health workers and promotores to receive to be hired and to receive payment, to receive a fair wage, to be able to be part of a system in the community while also benefiting with benefits and with employment opportunities. And as I see it, they are what we're looking at in terms of scaling workforce. It's an opportunity for us to really bring in community as part of that diagram.
Great, thanks, Maria. I'll go to Mar next.
Hi, good morning. Speaking from California, so good morning. Yeah, to just add to what Maria just mentioned, I think for us, I would say sustainable financing means really three things. One, equitable and just living wages or pay for promotoras, including for promotoras with ITIN numbers. Number two, it would mean contracting directly with community-based organizations who over the years have really incubated this community workforce model, right? And now we see, you know, states embracing this workforce, but really contracting with CBOs is really important to sustaining the workforce. And number three, along with contracting, also increasing the capacity for community-based organizations to build systems that will allow them to contract with state agencies. One thing is access, right? So as you know, we'll talk more about this later, but California is developing the community health worker Medi-Cal benefit, and under the benefit, community-based organizations can supervise CHWs, but you know, how do we build the capacity and the infrastructure for community-based organizations to contract with the state?
Awesome, thank you. I'll move to Richard.
For me, it's a little bit beyond the community-based organization. It is the ability to work with not having to worry about a paycheck, where it's coming from. Some hospitals and clinics should be able to bill for the position and work that community health workers provide. Community health workers should be an insurance billable item, not the medical system. And it's also because community health workers are part of the Medicare and the medical health system. It should be the same way that clinics and hospitals bill for diabetic health educators or dietitians, that they bill for services directly and not depend on grants. Another thing is, and it was a question that I've been trying to figure out for years, that over here we have a system called SERPAs, Certified Recovery Peer Advocates, and they work for OMH or Oasis Licensed Centers. These are mental health centers and drug centers, and they're allowed to be billed for services where community health workers are not. And it should be through the same methods that are billed, so that, you know, we could get reimbursed for our services. Not worrying about contract services, organizational pay, and things like that. This should be the same thing as health educators.
Great, thanks. And Shannon.
Oh, I get the privilege and the power, right, to go last. Everyone said such amazing things and just echo it all and support it all. I want to say that I think we need to look at this differently, right? There's been a paradigm shift in how CHWs have been recognized nationally, and we need to see this as not a limitation, but you know, what are the possibilities? When I see sustainable financing, it would be when we no longer have to talk about it. You know, I don't see us having roundtables about teachers or physicians. I'm sure they happen in pockets, but this is a continual sticking point for community health workers. And so I think we need to look at it in that light. The other thing, though, is creating funding for our community-based organizations that have historically hired, employed, and supported the CHW work, making sure that those are in place. Healthcare is part of the puzzle, part of the braided funding, but we have to have some other creative opportunities and focus on that as well.
Great. Those were awesome responses. So I think that will really ground us in our conversation moving forward. So as I mentioned earlier in kind of my level set remarks, this current patchwork of funding streams, they create challenges with respect to sustainable financing for CHWs. So I thought it would be great to start with Richard to hear from a CHW in the field a little bit about what that looks like on the ground for you. So like, how do these gaps play out in your day-to-day, and how does that really affect you as a community health worker?
For me, it's like when you want a multi-stream source of income, you have to consider time factors that each role plays. And what I mean by that is you have to break up your time in different contracts to make up the funding that you get paid. At one time, I was like on 3 or 4 different contracts, and I had to do 3 or 4 roles to get paid one check. I was doing community health work. I was doing health home outreach. I was van driver. I was doing SERPA services for drug treatment. And it's time consuming trying to manage all of that. You know, it's a lot of pressure. you have to play different roles. Plus, it doesn't allow me to concentrate on the profession, which is community health work. This is what I chose as my profession, and being scattered all around it's time consuming. It takes you out of your role.
Yeah, definitely. And so I guess my next question is for Maria. So we talk to people in different positions and important positions who feel like the federal pandemic funding that recently came through, or I guess not recently, a few years ago, or the new Medicaid benefits have really together successfully addressed the need for community-based delivery. What are the things that people in the policy and healthcare administration world don't understand about the experience of being a CHW or promotora, and really understanding what we still need to do moving past what has already been done?
That's an excellent question. Thank you, Natasha. As a promotora and having started founding ED of Vicente Compromiso 20-some years ago, 23 years ago, most promotores really we're traditionally volunteers. I think we kind of have to set the pace there, that we were mostly associated with churches or with agencies or just volunteering on our own. Over time, the role of a promotor, community health worker, has evolved and has really changed into one that has such a spectrum of services, from the community promotor volunteer to the community health worker who works in an agency. And much of what determines the role and the activity of that promotor, as Richard mentioned, is categorical funding. And categorical funding will determine for a CBO or for an agency what those activities are for that promotor, community health worker. We have been advocating for a long time that community promotores and community health workers should be really supported and funded by carve-outs, operating money, so that they can do the work that they do. That education, the outreach, the prevention, the navigation, all those things that we're famous for, but all those things that people want us for, is how do we connect to an agency? What is the dotted line of a person who walks out of a clinic with a diagnosis? Well, it's a CBO or it's a community clinic or somebody out there. It's a promotor, it's a community health worker who can connect to them and provide those resources. What I think what policymakers don't understand is it's not a straight line. You just can't. And we learned that through COVID, where we had so much funding that was going out to communities, and where in particular, promotoras and community health workers have been just lauded for all the great work that we did, for going into the fields, for bringing people to vaccination sites. And yet the funding is limited in scope because it's only for COVID. This should be for everything. We say that promotoras and community health workers have a position from preconception to death. If you think about the continuum of care, we should be looking at promotoras and community health workers in every activity. And so policymakers put us only in health, but really we should be in education, we should be in justice involved. You have transitions clinics that does that. We should be in every aspect of a family, and our community transformation model talks about that. It centers on that person and how we can support their leadership by supporting families. And really that's key to what we do. But I think policymakers don't understand that. And so we're parceled out, therefore the funding is parceled out. And Richard really talked really well about how it is that he was on so many contracts doing so much work, when in fact, if he had just one chunk of money that the CBO or that agency had, that would let him figure out, how can I best help my community? How can I best help that family?
Yeah, that's really great. And we're going to come back to the community transformation model later on in the panel, but that's really great. And I think a good segue into kind of the work that Shannon does. And so I'm hoping, Shannon, that you can share a little bit about what issues your clients face who are employers of CHWs. So when they work to reimburse their CHWs in a sustainable way, what does that look like, and what kind of challenges do they face?
Yeah, it was a great segue, Maria, and you brought up some really great points, and Richard as well, that the work that we do is often driven by the funding source or the, and again, back to the limitations. If I'm on a grant for housing, then I tend to only be able to work in housing when that's really not what's going to present itself to support the full picture of the community members that we're working with. And so as a CHW, it is very challenging to try to piecemeal together these items when really our value is the navigation piece. Our value is the ability to pull out those unseen and kind of hidden barriers and help move through and do self-empowerment. Who employers are, I see it as all, right? This is our frontline workforce, it's our faith-based organizations, academic, so again, back to Maria, it's not just health, although we have the word health, for the community health worker side in it, that tends to sometimes make it a little bit clouded. So our housing providers, again, churches, faith-based organizations, I've seen for-profit employers have CHWs as part of their employee benefits programs. I mean, really, anybody in my mind can really benefit from navigation services, and remember that it's for all. Yes, we often see in the public eye that CHWs and promotoras help with those that have, financial barriers. But I can tell you in my line of work, the majority of people I'm working with are either situationally in something and or have means. They just don't have the navigation skills or have so many other things going on that they need that support. So when we look at reimbursement models, I believe we have to look at it in that fashion. I often think about how are our CEOs at nonprofits funded? It's through multiple funding that's been braided together, whether it's indirect from a grant or it's this specific earmarked piece of the project, or it's operational dollars that come from their donor funding base. For our community health workers, we have to be more creative and piece those things together in a way that supports their day-to-day work, but also at the same time, not pass that data tracking burden to that CHW who is so valuable in their skilled trade and needs the focus on their work. Them having to track all those pieces can really distract from the day-to-day work and the client engagement. But there are ways to do it, and there are ways that many have been very successful. And just the last point I wanted to bring up, you talked about volunteers. That's a valuable point to know that yes, lots of us, myself included, I've had both paid and volunteer CHW work, but it doesn't mean that it's free and that it doesn't have a cost. There's still a structural cost to it, and we still need resources to support that programming.
Thanks, Shannon. And yeah, so talking a little bit more about kind of multiple streams of funding, multiple funding sources. I know, Mar, you've been involved, and Maria as well, with developing the new California Medi-Cal CHW benefit, which is set to take effect on July 1st of this year. So as we all know, there are other states that use their Medicaid programs to reimburse CHW services. So it would be great to hear from both of you, maybe Mar first and then Maria. What factors did you consider when designing the benefit, and to what extent did other state models influence how you thought about it? And yeah, let's start there. I have a follow-up, but we can start with that.
Sure. Yeah. I can start off. Well, I'd like to quickly respond to sort of this elephant in the room that we're all sort of talking about in our own way, which is this conflict, this, I would say, historical conflict in terms of the clinical setting and then the non-clinical setting, right? And as we start to see states, right, states have been embracing the CHW model. They definitely see the value add to the workforce, what these workers bring, how they advance health. We don't want to lose sort of the community-based element that makes this workforce so unique and special and effective, I would say. And so, as we design the California Community Health Worker Promotora Medi-Cal benefit, I think that was something that LCHC was really interested in. I know that Maria and Visión y Compromiso were really interested in, is how do we make the benefit as expansive as possible to include as many services as possible, knowing that CHWs have a wide range of skills that can perform several different types of services, and how can we bill for those under Medi-Cal, right? And so, I'd love to hear more from Maria around a specific state program, Medicaid reimbursement model. But I think for us, what I heard in our stakeholder process was actually really leaning on the C3 model, right? So the core consensus project, or the C3 project, which really is a national sort of guide that puts together the core competencies of a CHW, right? They did this, they developed this guide really with the input of community health workers nationally. So we do see this as a sort of agreed upon guidance around what these core competencies for CHWs should be. And many of those core competencies do appear in our final state plan amendment. And if you look at them, there are things like communication, interpersonal relationship building, capacity building, advocacy, outreach, right? So some of these things, aren't necessarily within the clinical setting. And if you look at the services that we included and really negotiated with the Department of Healthcare Services, who we met with periodically to develop the state plan amendment, we're talking about services that include health education to promote, right, health navigation, which I've heard a lot about here, to provide information, training, referrals, provide cultural liaison services, right? So our ability to really feature and highlight the cultural competencies that this workforce, this very diverse workforce, has. And so all of those were included in the final SPA, the state plan amendment that we submitted to CMS. Not all of the things that we hoped for were included, but I think that it is definitely, one of the things that we had in mind is to make the benefit as inclusive as possible, as expansive as possible. And, we can touch more on this, or maybe Maria would like to touch more on this, but also the ability for community-based organizations to contract directly with the state is also, I think, a really important win, and something that I think, we're really proud of. But I'll hand it to Maria to add to anything that I've mentioned.
Oh, Maria, I think you're on mute. Give me 1 second.
There we are. I'm really heartened by the discussion about something like C3. So Visión y Compromiso and I've been part of the C3 advisor committee 10 years ago. And when a lot of the national community agencies got together to start looking at how it is that we can describe the work of promotores and community health workers, I don't think we thought it would have this kind of impact 10 years later. And Carl's on the line, and Carl was one of those also was part of the advisory committee, along with Lee Rosenthal, who led the effort. And we had hoped that we could establish these ground rules for community and for agency, so that there was a respectful relationship to the promotor and the community health worker, and the definition that you gave in the beginning, Natasha. And so how do we merge those two? And that, I think, is what has come today. The biggest problem, I think, that occurred when we started talking about the CHW benefit and the funds that were allocated by the governor was that it was tied to Medi-Cal. And majority of CBOs are not tied to Medi-Cal. And many of the community promotores are with CBOs, either as volunteers, and hopefully they will be employees. And so that's where we had the difficulty. The process was really defining how can we open those doors and allow CBOs with a carve out to them, to grant to them, so that they can then engage in hiring more promotores, community health workers at the community level to formalize this relationship. Not just, we look at health, not in the small physical health, but we look at it as the big health. Our community transformation model looks at the community transformation starting with the individual, and the socio-ecological model, which looks at everything. And so while the community health worker model has been associated with clinics, it really, in the community, it looks at everything. And so you find promotores, community health workers in everything, in resource centers, in Girl Scouts, promotores in Girl Scouts, or in everything that you can think of, because they want to help their community in whatever agency or activity that they're in. And so what we hope is to expand that. And this discussion that we had with DHCS about the benefit was really, I think, a first step for them to integrate community in a real way, to look at carving out money to regrant to CBOs, to be able to hire and to build up their own capacity, their own sustainability with operating funds, for instance, to hire promotores. So it's a big step forward. It is different from many of the other states who are requiring reimbursement, and the guidelines of Medi-Cal, slightly different. We haven't finished with it. We're still in discussion. I believe the DHCS is still open to some discussion. But I think we're hopefully leading the discussion for the nation in how it is that we can redefine some of those requirements.
Awesome, thank you, Maria. So we have a couple minutes left of this panel discussion. I want to make sure we have time left to answer some questions from our audience members. But I think to wrap up, so I think we've well established kind of what the gaps look like, what the issues look like. And we started talking a little bit about what we really need to see. So I wanted to go around and ask folks to share maybe in a couple of sentences, 2 to 3, kind of what models have worked well. And I know that we can get really deep and have another hour-long conversation about exactly what that technically looks like and the mechanics. But I'll start with Richard. Can you share some reimbursement strategies that you have worked with or experienced during your career as a CHW that you felt really helped you to perform your full range of services while receiving adequate compensation?
Yeah, sure. I think the Transitions Clinic Network model has worked well. The Transitions Clinic Network has adapted clinics, and what their model is hiring CHWs to work directly for the clinics so that they could provide the service. Now, the clinics will be able to get grants or whatever, but the service is that direct service. So they establish a model that works. Now, sometimes, additional funding is needed. And like I said, the Medicaid, Medi-Cal items are needed so that they could continue services. But I think the best one overall that I've experienced is the Transitions Clinic Network model.
Great, thanks, Richard. Maria, I know you touched on this pretty well, but I don't know if you have anything you would like to add about the community transformation model and how, maybe speaking a little bit about how advocates can begin to start building these frameworks in their own communities and kind of any guidance you might have on that. I know it can get, I know there's a lot to say about it, but.
I'll just try to say that the Visión y Compromiso supports promotoras and community health workers. The title of our network is the Network of Promotoras and Community Health Workers. So we embrace everyone within that, not just Spanish speakers and not just Latinos, but everybody. We're training in English and in Spanish right now. It is a model that we hope will be fully realized. Someone said that there's an army of promotoras and community health workers out there. They're already doing the work. They're already linking resources. How can we support them? Because it becomes an equity issue, it becomes a financial equity issue, it becomes a woman's issue. The majority of promotoras and community health workers are women. So there's a lot more nuances to it. And the reimbursement piece is such a small piece of the discussion that if we're able to carve out money to really support CBOs to hire the community leaders, and then we can carve out a piece for those who are in the reimbursement field, but really look at how do we form the partnerships? How does a clinic really work actively with the CBOs that are doing this work as volunteers or adjacent to it? How do we expand this model to integrate everybody to be in support of community wellness? That I think to me would be great.
Awesome. And this next question is for Shannon. In your experience, what should people consider when designing their own sustainable models? What are kind of some of the key takeaways you would say that working with employers that you'd really want to drive home for other employers of CHWs looking to sustainably finance the workforce?
Yeah, this one's a hard one because it depends on the organization, but at the same time, no different than any other member of your team. As an organization leader, you do have to look structurally at how do they fit? How are we designing them? All too often, we find that community health worker programs become the add-on, and they're not intentionally integrated into the structure. There's no career ladders. There's hardly a job description. So then why are we surprised there's no sustainability, right? It's like, because you didn't start with that. We have to start with the end in mind. And then it makes the rest of it a little bit easier. It might take a little more time, but it will be more sustainable. I think the other piece too, there's a lot of questions around some of the barriers to CBOs being able to contract with Medicaid. Again, I'll always emphasize Medicaid's one payer. In Michigan, we have, I think, a phenomenal contracting mechanism where it's not fee for service, where we have open-ended contracts that you have the autonomy to design. So the community-based organizations and that Medicaid health plan design those together. But one of the biggest kind of blind spots that I've noticed when I've helped to support them is the cost of insurance. So how many CBOs off the cuff, right, or how many churches have cyber liability insurance? And then sometimes, that's an additional $5,000 to $10,000 a year. And so when you look at the end result, some of the extra incurred expenses and infrastructure that a hospital system might already have, right? Because this is their world. As CBOs, we have to get out ahead of that and learn that curve. And that's where you see some of the hub-based models working really well. Like we saw a few things in the chat around how do we funnel finances and maybe work stronger together. In some areas that might be the best option, and others it's not, right? Let's build up the capacity for the CBOs to be able to do it themselves. So again, unfortunately, it's like not a one size fits all, but there are a lot of different options where you don't have to depend on grant funding, and contracts can be the better method.
Great, thanks. And then we will round us out with Mar. So I think it would be really great to hear a little bit about what you think are elements of the California benefit that are probably most innovative, things that I know you mentioned a couple of things you were proud of, anything that you think really stands out and you feel like is really like pushing the limits on and redefining perhaps what a CHW Medicaid benefit looks like. Yeah, anything you'd like to share on that?
Yeah, I think I mentioned this briefly, but really, I think the highlight for us was the win that we got when we were able to have community-based organizations be supervisors of community health workers. So, the reason why that is so exciting is because CBOs will have the opportunity to become providers, right, with Medi-Cal. Now, that's not to say that there aren't, challenges related to that, because we very well know that, the state is bureaucratic and there's a lot that, a lot of hoops to jump through, et cetera. It's not easy at all, but I think we at least are seeing the recognition that community-based organizations are the incubators, are the holders of the CHW workforce, right? And so now the work that's left to be done is to make sure that CBOs are at a level playing field with other CHW service providers, right? And so again, the work doesn't stop. We need to ensure that equity is embedded throughout the entirety of the program. We're working with DHCS to make sure that this new CBO provider pathway is equitable, that there is capacity building baked into that, because of course, we're new to this, right? We're new with contracting with the state. And so we want to make sure that, that we can do it, because it's worked. We've seen the way our CHWs, our promotoras have been effective COVID-19, right? When the state was overwhelmed, when our counties were overwhelmed, community-based organizations stepped up. We were able to fill that gap. We were able to get the good messages out there. And now we want sustainable funding. And so we look forward to the opportunity to continue working with the state to make that Medi-Cal benefit equitable for everybody.
Natasha, I want to just touch on that, because I think what's really important that Mar said is that in each state, those of you from other states, is what made a difference, I think, was a diverse coalition coming together and really being able to speak different voices in tandem to say community is important. COVID and the success of COVID, money's flowing swiftly and in great numbers to CBOs to be able to hire community leaders to do this outreach and education. was critical. And I think the experience of COVID, we should take that on and move forward and value the learnings from that. And then the coalitions that come forward, like the ones that we had with Latino Coalition, with the Children's Partnership, with CPAN, who took the leadership on this, really bringing forward the voices of policy, but of community. Policy cannot do it all. Community has to be at the table, and community has to be able to speak the authentic voice.
Awesome. Yes. And that is, I think, probably one of the key driving themes in especially the CHW movement. But thank you all so much. I know we only have a couple of minutes left for questions, but this conversation was amazing. And I think it was important to hear about from all of you, from your perspectives about what we're dealing with right now and kind of where this movement needs to go and kind of what really needs to be done to make sustainable financing possible. So I'm just going to raise up a couple of questions I see here in the Q&A chat box. One of them is from a participant who says, considering the strategy to move away from categorical funding to more flexible or unrestricted dollars, what's the best way to funnel government dollars in that way to CBOs that may not have an extensive development team? And I'll just open the floor because I'm not sure. I'm sure many people here have expertise in that. So feel free to pipe up.
So I'll say that has been an ongoing discussion for us. And part of the regranting component includes sustainability for organizations, their ability to be able to not only develop a proposal to submit, but to have the financial infrastructure to be able to accept those funds and process them. Small and medium-sized organizations don't necessarily have the capacity. And so we have to resource them to build that capacity to be present in this discussion at the local and county and the state level.
And I would just add, what I mentioned earlier, coming together to be stronger. So maybe you're an employer that has 2 CHWs, maybe you have 10. If there are efforts or initiatives that need 20, find a partner, right? Because you can share your data person, you can share your biller, you can share your CEO and your leadership. All too often, unfortunately, with duplication, we have a lot of cost wasting that does not trickle down to the actual CHWs. And we talked a lot about wage equity. Our community health workers and promotores are one of the lowest paid workforces and doing one of the highest skill levels of work. And so just something to consider that it is a benefit. It's not a weakness to partner if it's going to make sure that you can have better pay and benefits for your team.
And also allowing community health workers to tap into the crisis intervention units. I mean, there's a lot out there and we're not using that funding the way it's supposed to. A lot of people put RFPs for crisis interventions and they put skilled professionals, yet they send out the CHWs to go do the work. I think, it should be a fair compensation and organizations should adapt the model to apply for these grants so that they are able to maintain community health workers on their payroll.
Awesome, thanks. And noting the time, I do want to be respectful of everyone's time. Thank you so much to our amazing panelists for sharing your experiences and sharing your wisdom with everyone here today. I know I can speak for all of our participants when we say this was such a much needed, valuable discussion, and definitely more to come. This is not the end, this is just the beginning. So I just want to remind panelists really quickly that we do have a post-webinar evaluation to see how we did, hopefully answered your questions and see kind of what you're looking for from us and how we can be helpful in your advocacy efforts. So once you close out of this webinar, the screen should pop up immediately. Thanks again so much for your attendance and your participation, and these slides and a recording of this webinar will be posted to our website once this is done. So thank you all so very much. I hope you have a great rest of your week and talk to you later.